All right. Good morning, everyone. Welcome to ISG Masterclass once more. Uh, this is the 24th lecture on Masterclass, and we believe that this has been a beautiful journey all over these last almost 24 weeks during this pandemic. Last week we had a midterm conference of SGEI, and I think many of you would have attended this session on SGI. We're coming back to our master class, and today we have again yet another important topic that is chronic pancreatitis. We'll focus today only on management of chronic pancreatitis, and again the point is of all this master class that we want to change the practice pattern in our country and all over that, and we only focus on those topics which are very important for practice points. And for that, we have again, very renowned speaker, Dr. Manu Tandan. Dr. Manu Tandan is a senior consultant at Asian Institute of Gastroenterology in Hyderabad. He is in charge of academics at that institution, and we know that the institution is supposed to be one of the best in the world in gastroenterology. And we are also proud that one of our institutions of our country is now leading the world in gastroenterology practices. So, and he has done a lot of original work on chronic pancreatitis, especially management of stones, and he had a lot many publications to his credit on this very topic. This topic is very dear to Dr. Manu Tandan, and he always tells us that this is his area which he enjoys the most, talking about chronic pancreatitis. So we'll hear from him on chronic pancreatitis. We will hear more from Dr. Saraswat because they have been contemporaries in their students' life. For moderating this session, again, we have one very dear senior colleague of ours, Dr. S.P. Misra. I think everybody, all of us know him. He has been the president of ISG. He had led the society, our society, as a secretary for almost 6 years, and lot many changes has come during his leadership. He is a professor of gastroenterology at MLN Institute of in Allahabad. And one thing, some of you those know that he is a great singer. So certainly we'll not have time to listen to him today, but certainly we'll focus more on the academic part of masterclass today. So with this, we welcome you once again, and may I request Dr. Saraswat to introduce the speaker, and then we go back to our lecture. Dr. Saraswat, please.
Thank you, Dr. Govind. Very good morning to all the participants, and a welcome to this 24th edition of the ISG Masterclass. As Dr. Govind has already told you, we started these masterclasses way back in April, 16th April to be precise. And over these 4 months, I'm happy to note that ISG Masterclass has set a kind of a precedent and a trend for the virtual teaching in gastroenterology and in many other areas for the whole country. And today, apart from ISG, we have had leading programs and webinars from the INASL, who are doing a research methodology series. Many of you would have participated in the recent SGEI midterm virtual conference. And a lot of now the virtual calendar is getting very crowded with a lot of events and programs led by institutions and also supported by industry of quite high quality available to the viewer at present. As you all know, the ISG annual conference this year is going to be a virtual event in the 3rd week of December, 19th and 20th of December. And we propose to continue with the ISG master classes till close to this time. Many centers in India are presently, the DMDN candidates are appearing for their theory and practical examinations all over the country. So a very loyal group of a part of our audience is a bit somewhat preoccupied with the exam concerns. But nevertheless, I think What we, towards the end of this session, I expect Dr. Govind will tell us about a slight change in the format that we are contemplating as we move towards a series of webinars on GI oncology, which has now merits recognition as a specialty in its own right. For today's session, it's a great pleasure for me to welcome Professor Manu Tandan from the Asian Institute of Gastroenterology to speak on the topic of chronic pancreatitis, which, as Govind has said, is very dear to his heart. Manu and I go back a long time, almost 3 or 4 decades. I stepped into the seats that Randhir and he vacated at the All India Institute in 1984, 85. And Manu and I have um, uh, a lot of things that we have shared from our MD days. Apart from our interest in the pancreas, I think both of us share a deep interest in history, for which we tend to share with each other whenever we get together. So with these few words, I think I'll welcome Dr. Manu Tandan and request him to deliver his lecture on chronic diagnosis and management of chronic pancreatitis. Manu?
Yeah. Thank you, Vivek. Thank you, Govind. I think it's a privilege to be speaking to. Just 1 minute, I'll get my slides on. Yeah, full screen.
Yes, we can see your
Yes,
slides, Manu.
now you can. So thank you, Govind. Thank you, Vivek, not only for the introduction, for the privilege of giving me this opportunity to talk to you about pancreatitis. And I'd also like to thank SP, who's going to moderate the session, because his inputs were helpful in making the questions and some of my slides. What I propose to do in the next 40 minutes, we'll have a break halfway through, is talk to you about management only, because management is itself a big topic. We'll start straight away. Now, all of you know, irrespective of the etiology, chronic pancreatitis is an irreversible illness. You will have pain as a dominant symptom. It may be as high as presenting in 75, but it can be 95% of patients, it will come sometime or the other. And people not in our country, where idiopathic pancreatitis is more common, alcohol, if present as the etiology, the pain incidence is more. Whenever we talk, coming straight away to the topic, whenever we talk of pancreatitis, we talk of pain, exocrine insufficiency, and the complications of pancreatitis. Let it be very clear when you are managing that there is no cure yet in pancreatitis. I'm not talking about pancreatectomy and islet cell transplant, being more practical. Now, clinical scenarios come in 3 settings. You will have someone with a ductal obstruction, which could be stricture or calculi induced. You could have pain or the symptoms after decompression, either endo or surgery, or you could have a pancreatitis with hardly any ductal change. And depending on this, we will tackle our management. We will, the mechanisms, again, this is a topic in itself. The management, the mechanism of pain is multiple. The commonest in more than 60% is ductal hypertension due to an obstructive lesion. You have oxidative stress, which I'll tell you later, induces inflammation. You can have nociception. For those of you who don't know nociception or not familiar, nociceptors are receptors which identify noxious stimuli. The noxious stimuli can be pain, inflammation, can be pressure, can be pain. And then it is carried via the spinal cord to the brain. So you can have neural mechanisms, ischemia, inflammation, and ductal pressure. All these can contribute to the pain that is present in pancreatitis. Let's begin with pain. How do you manage? We'll tackle all these one by one. Well, very obvious, alcohol and smoking. Smoking is an independent risk factor. I'm not talking about etiology. Must be stopped. There is no respite if you continue your habits. The role of diet is a little debatable. People say you can take a normal diet. People say you can take what you can tolerate. I'm just raising some issues which have been raised in the past. The evidence is really not very strong. Small feeds, not very fatty, rich in folate, especially for alcoholics, and in antioxidants. So definite lifestyle changes, especially getting rid of any precipitating factors. Then we come to pain. The WHO ladder is nothing new. All of you are familiar. The only difference in our country is we rarely use morphine and pethidine as a part of pain relief. If the pain relief does not come with, let us say, tramadol, opiate agonist, then we either use a patch or may think of an celiac block, which I will talk about a little later. So the pain ladder, start with the minimum dose, go up, see that no addiction takes place. All of us know the negative effects of using painkillers right from NSAIDs and the opioid bowel also. What about oxidative stress? Now, pancreatitis is a SNR event. And at the SNR level, you have these free radicals which are produced. And from this slide, you can see that eventually it leads to mediating inflammation, leading to the development of pain. So are we justified in treating with antioxidants as a part of therapy? This is a randomized, this is a meta-analysis chart. It's a very busy chart, don't go about it. 6 studies spread over 30 years. But I'm going to concentrate on one, Pramod Garg, which is from India and very well quoted, where he used this combination. And what were his conclusions? There was a reduction in number of painful days. There was a reduction in number of analgesic tablets, and a number of patients who became pain-free were higher. And so he concluded that this supplementation was helpful in patients with pain with CP. Okay, there are many skeptics. Does it really work? And then there was this study from UK, Sirivardhana's. This showed the other end. This showed that there was no benefit. So what they found out that in either group, both with antioxidant and with placebo, there was really no change in the overall pain relief and analgesic use. But then there were some dissimilarities. Basically, Sirivardhane's group took patients who were more severe, patients who continued alcohol and smoking, and patients who were older and using opioid. They are the ones who didn't respond. Whereas Pramod and Bharadwaj's group, they in a sub-analysis says that people who took alcohol as an abuse still after the onset did not respond, whereas the others did. So maybe in our variety where idiopathic, we have a study of over 8,000 patients. I'll come to it a little later. Only 472 had alcohol and smoking in significant amounts. The rest were all idiopathic. So we did a lot of studies on that, and we found that methionine, especially in important quantities of as high as 2 grams per day, will supply the methyl and thiolol moieties, and this will help reduce the pain. So this was what we concluded, and this was mostly in idiopathic chronic pancreatitis. If you have a small duct disease, I told you neural mechanism, either neural pressure or nociception, any of these drugs could be pregabalin, could be an SSRI, or could be a tricyclic antidepressants, where all have been used with variable degree of success. It may be worth trying, especially in a small vessel disease where there is no role of a small duct disease, where there is no role of endotherapy or surgery. Soren, we are doing a study with Soren on pain in chronic pancreatitis. It is Scandinavia and AIG. He had this study where he found that pregabalin helps, especially when neuropathic pain is dominant. You get rid of Ductal hypertension, if it doesn't improve or there's a minimal duct, use pregabalin, and found there was an improvement in the pain score. We did a combined study where we combined both pregabalin with an antioxidant. This is again in the group who have no significant ductal hypertension, and the mechanism most likely is neural, and found it to be beneficial in all those patients where the ductal hypertension was either treated or not there. This role of pancreatic enzymes, this is especially for pain, I'm going to take at the end of the talk when I talk about the exocrine insufficiency. Now, the second important after pain is exocrine insufficiency. We are not going to about type 3C diabetes because that's a separate topic in itself, and an endocrinologist probably will tackle it better. Now, enzyme insufficiency, all the three enzymes eventually go down, and that is how malnutrition occurs, and malabsorption, malnutrition. Most of the time, it is a compensated PI. There is a decrease in the output, but clinically there is no significance. And decompensation only occurs if there is extensive destruction and more than 90% of the pancreatic parenchyma is destroyed. Now, there is a school of thought, because clinically it may not be evident, that you can start enzyme replacement if there is weight loss in chronic pancreatitis, excluding malignancy and diabetes. There is no other cause. You feel it's only pancreatitis and significant weight loss, you can use enzyme. That's a school of thought. What is the incidence? Most of the people develop exocrine in the second or third decade. Only in alcoholics it occurs early and in the first decade. We had this study where we found that ICP, idiopathic chronic pancreatitis, it was generally in the second decade. And most of the time, when it is severely decompensated, you have clinical evidence of steatoria. Let me tell you, the steatoria in our series of first 5,000 was less than 8%. One of the explanations given was that Indians as such have low fat, and so probably the steatoria is lesser. Now, of the enzymes, lipase is the rate limiting factor. Many reasons are given for it. First, lipase has no substitute, whereas amylase and the proteases are available, let us say, in the saliva on the brush border. Lipase is degraded very quickly. It is degraded once the pH is low. It doesn't rise above 6 because the bicarbonates also are low in chronic pancreatitis. And you begin to get clinical malabsorption as steatoria when it drops to 10% or less. So you will see that most of our, I'm not mentioning any enzyme preparations, that when they say number 20,000, 40,000, 10,000, it always means the lipase units. Unfortunately, we don't have a uniformity. People write USP international units. We are yet to get a uniform marker of lipase measurement. Is enzyme therapy new? Vivek told you I'm a fan of history. 1937, 1941, people much intelligent than us before any investigations have published data that enzymes are beneficial in pancreas. They are giving the strengths also, and these are papers from 37 and 1941. How do we give them? There are two forms, enteric coated or non-enteric coated. You know, this coating, when you do their microspheres and they are pH sensitive, it dissolves only in the duodenum, and then when the pH goes above 5 or 6, it begins to take action. SP especially pointed out there is a strong limitation to this. Enzymes are only from porcine yet, and it may be offensive to certain sects of people. Unfortunately, we have no genetic engineering yet for enzymes to replace the pancreatic enzymes. How much do we use? There is no single cut. We at our institute generally give between 25 to 40,000 with a meal and 10 to 25,000 with a snack. In cancers, it is advised that you take as high as 2 lakh units per meal. You should take it ideally at the beginning of a snack or in between a meal. If you are having 2 rotis, have 1 roti, have the enzyme and take the other one. Now, there is a flexible and individualized enzyme therapy. There are companies which have come with a device where you can titrate the dose according to the diet you take. You take a very high fatty food, you can increase your dose. So that is a new development in the delivery system. Should we use the PPI? Yes, you should. This is just because we need to raise the pH at least above 5, ideally above 6. Otherwise, there is no active action of the microspheres. So, must use a PPI whenever you are using a pancreatic enzyme for PEI. Yet, we have patients who don't respond. This could be ideally for many reasons. Non-compliance is the commonest. Low dose, inappropriate dose, inappropriately taken, the cost. It's a lifelong therapy. It's very costly. Sometimes with gastroparesis, the microspheres just don't enter the duodenum. They get degraded because they just keep sticking in the stomach. And if you use some of these preparations, calcium or magnesium, binding takes place and the spheres are not able to deliver to the regular site where they need to be. I told you I'll talk to you. Do these have any role in pain? How does pain and enzyme act? Now, serine protease is one of the proteases which stimulates CCK if it is deficient. Now, in chronic pancreatitis, this goes down. You get an increase in CCK, pancreas is stimulated, and then you get pain. So, if you want relief, you need something with high proteases. If you want relief for malabsorption, you need to have high lipases. So if you need both, you have protease and lipase. Unfortunately, again, I say, and SP and I were discussing this, not many preparations in our country at least have got a high protease. Let us see the role in pain. Well, I am quoting, there are many studies, but I am quoting from PGI, Dr. Bhasin's group, Surinder Rana and Shafiq. They did a Cochrane analysis and found 361 patients, and look at their final conclusion. No definite conclusion can be drawn. This was 361 patients, 10 studies. No definite conclusion for the benefit in pain management. And then we had this meta-analysis which showed 4 of them showed benefit, and mind you, all of them were non-coated, and most of the preparations we get today are coated. So if you think pain it may help, then you need a high protease and a non-coated enzyme, where showed no benefit. So the jury is still out. If you have nothing better to try, then try a non-coated and a high protease enzyme. I think SP, as I told you, we'll moving on to the next part. We have discussed pain, antioxidants and enzymes. We'll take a break here, and if there are any questions, SP will put it forward. I think any one of you can put it to SP and we will take it over.
Come in, sir. Sir, can you put your camera slide? Yes, slightly.
SP, you have to change your angle to half your face is seen.
Yes.
And demute.
Unmute, yeah, perfect.
Unmute.
Can you see me now?
Yes, sir, yes. Sir.
Yes, a little better, SP, fold it a little better, we need to see you.
Now?
Fantastic.
So there are lots of questions, and I think, Manu...
you collate them for me, because I don't think we have the time to answer everyone.
Okay. I think during your AIMS days, you were favoring Vivek rather than Shiva. Shiva has lots of questions for you.
Oh,
So Shiva from Visakhapatnam is, one question is there, how does one objectively differentiate contribution of ductal hypertension versus other factor causing pain?
Shiva, we'll come to that. Ductal hypertension generally occurs in two conditions only established. The rest is all speculation. If there is a significant stricture either in the main duct or one of the main side branches, but mostly main pancreatic duct. And the second is a stone which is obstructing the lumen. These are the two objective things. You can do it on a good imaging. I prefer a good MRCP rather than a CT to identify that.
Manu bhai, has somebody measured the pressure?
Earlier it was being measured. When the strictures were going to be treated, they were measured. That practice has now been abandoned.
Second question from Shiva is, what is the best objective pain score to decide necessity of stepping up pain management?
Shiva, this will take another 40 minutes to go. Starting, we have ISBSCI score is too complicated. There is a specific pancreas score. Soren's, which we are doing, we are going to adopt that score. It will come out now. We, for our 7,000 patients, which we have published, only used VAS because some of it was telephonic. For practical purposes, when you are on a phone, probably the VAS is the most convenient. It has many loopholes because it is subjective. But ISBSCI is very complicated. The new one, hopefully, will let you out in maybe about 6 to 8 months.
Dr. Jayanti, you asked a question about enzyme replacement. He's already said that it has, Dr. Bhasin's meta-analysis, that there's hardly any role. So I think that your question is answered. Again, Shiva has one more question. Is there a single biochemical parameter that can indicate the need of enzyme therapy in patients who have weight loss?
Practical purpose, clinically, weight loss and fecal elastase is what we do for practical purposes.
Do we have a to give it? Only lipase.
Fecal elastase and weight loss. Besides, of course, tituria, which is very obvious.
So can you repeat the question, sir? You have a...
Do we have a preparation having only lipase?
I don't know if one of you can answer. To my knowledge, no. The common ones I use have got more than lipase. So I'm not sure, but if anyone of SP, Govind or Vivek has got an idea, you take it. I don't know.
So Kailash Kole from Mumbai, if pain resolves, patient improves nutritionally, can the patient be given stent-free trial? We have not talked about stent, I believe.
We have not yet come. If there is no, if he is relieved, you know, stenting and stone, we will come only if pain is present. There is no indication of blasting stones if there is no pain. So symptom relief, what are you going to remove the stone for? To relieve pain. He has no pain. Why do you want to bother putting in a ESWL and ERCP?
So there's a question from Dr. Pradeep Nigam from Riva.
Yes.
MP. One side you said that Indians have low fat, but studies have shown that they have high visceral fat. NFLD.
Vivek, your field, please. I passed the question.
I think you can move on to the next one. I think this we can
This
answer.
is a tough one to answer, Dr. Nigam. We have, I think it's a genetic build with truncal obesity. You know, the majority of the ICPs that they come, very few are really obese. Most of them are thin built and they don't have obesity. It's not a general rule, but I'm just telling you.
Dr. Shubhamoy from Kolkata says, why non-coated enzyme? Because they have been found to be better in trials.
Yes, in pain, especially in pain, not for malabsorption.
So this answers Dhruvin Shah's question from Chennai, whether coated or non-coated. Non-coated is better for pain.
Yeah.
Dr. Ramkrishna Baral from Kathmandu, he's asked, role and dose of pancreatic enzyme in chronic pancreatitis pain management. You have already told about that.
I feel there is no role really in the present preparations.
But what about the non-entry ones?
SP, are we getting them in the market non-entry?
That's the problem.
That is, you know, what all they come and project to us is microspheres, entry coated, good delivery. We don't need that.
Dr. Arun from Chennai asked, do we need to give PPI? PPI is given to decrease the pH. Basically.
Yes, to make it 6 and above, 6 and above ideally.
Dr. Matthews from Chennai asks, how much protease is required for pain relief?
That's a tough question, Matthews. That's a very tough question because we don't have studies. You know, the 4 studies, all of them had less than 10,000 units. Again, the units are different in each pharmacopoeia. So less than 10. We have no controlled studies with high proteases or an optimal dose.
Dr. Alvin, your question has been answered from Madurai that is non-coated available. Non-coated is not available in India. Dr. Bhavesh from Bhavnagar, how common protein and carbohydrate mild digestion in chronic pancreatitis?
Well, much later than lipase. You know, pancreas, amylase is available in many sources, protease is available in many sources. So if the diet is adequate and there is no restriction in the diet or intake for any reason, it's unlikely. But if nutritionally because of pain he goes down, then you'll get all the 3.
One question from somebody, he asked, how long should we give PRT enzymes?
Actually, lifelong. Theoretically, if your finances support it and it's an irreversible disease, unlikely to improve totally.
Then the Dr. Gopal from Mangaluru is asking, is there a cutoff from CA99 in patients with acute exacerbation of chronic pancreatitis without malignancy?
That's if there is cholangitis in my hospital, even up to 200, we are not bothered.
No, nothing.
Even if there is cholangitis.
Yes.
So can we go with lecture and we come back again?
Okay, I believe we have to move back to the lecture.
There are many questions coming up. Never mind.
Okay, so shall I start the lecture again?
Yes.
Okay, now we come to what Govind and Vivek told me. My favorite topic, endotherapy of chronic pancreatitis, pain relief and associated issues. Well, this is pancreatitis. Irrespective of the etiology, all this happens in chronic pancreatitis, and that is why it is a challenge for the endoscopist. And this is what we are going to see very briefly in the next part of the talk. We are going to tackle this one by one. We were fortunate to work a lot in this field, and this is an invited review. Endoscopic approach, we have 2 types of issues, minimal duct disease and Shiva's question, large duct, where there is ductal hypertension because of a lesion. Well, again, history, Vivek, I cannot miss history without, in my talks, the 2 pioneers, Peter Cotton on your left and the late Michel Kramer on your right. They are the pancreatic endotherapy specialists. See Peter Cotton's car. It is labeled, numbered ERCP1. Probably one of the earliest to do ERCPs. Dr. Michel Kramer was a good friend of our institute, and our ESWL, which has now gained recognition world over. Initially, I was lucky to have his guidance when we set it up, and the biggest sort of a boost came when 5 years later, he sent his resident to come to us to learn ESWL. So Kramer, till his death, was a very good friend and supporter of AIG. These is from his own charts. The first 6 pancreatic endotherapies is done. It's in French. I can only tell you in the lower half, one of them died deceased, and he thought it was because of Valium. And if you see 3, he was unable to cannulate. So even the champions, don't worry if you're not able to do an endotherapy. These are the champions. This is all when he came, he handed it over to us because I was keen to get. And this is the first case of pancreatic stone that he removed almost 45 years ago. Mid-pancreatic calculi removed at ERCP. Excellent. So these are the champions whom we have followed today. Coming to the topic proper, what do you do if there is a minimal duct disease and pain? I told you, you have tried all the earlier things. You have tried pregabalin, you have tried antioxidant, you have given pain, the patient is not relieved. I'll talk about celiac block a little later. But if you have no options, worth giving a sphincterotomy to the major papilla. More than 60% will show a response, though restenosis is seen in 15. Same happens in divisum with chronic pancreatitis. Peter Cotton did it the first. Almost 50% will get a relief. The restenosis rate is obviously higher because you make a smaller cut, the mound is smaller, your cut is smaller. Now, a question which are practicing, this is more meant for the gastroenterologists who are doing ERCP. Do we need to do a biliary sphincterotomy? Yes. If there is cholangitis, if the CBD is persistently 12 or more of the alk-phos is at least 2 times above the normal on 2 occasions. Sometimes we do it just to access the main pancreatic duct, but that's a relative indication. So let us take the lesions one by one. Stricture Shiva, earlier there was a pressure measurement. There is no longer a pressure measurement. The only thing we must make sure in malignancy, 10% or more in Ramesh's study, we find the incidence a little lesser than that. What eventually turned out to be malignant after 20 years. But if there is a single stricture, you can attempt endoscopic therapy, maximum with 2 proximally. If there is a chain of lake, send it to the surgeon. Dilate it with either a Sohendra or a balloon or a bougie and push in a stent. You may get a relief, as I have mentioned, between 70 and 90%. This is, we are dilating a stricture with a Sohendra, and a single pancreatic stent gives relief, as I told you, between 70 and 90, but there is a very high recurrence rate once you remove. Unfortunately, till today, the guidelines do not talk about type of stents, number of stents, when do we exchange. Most of them is arbitrary when you have symptom or when you come after 3 months. Costamania, you know, did multiple biliary stenting. Well, he also propagated multiple pancreatic stenting, where he found multiple plastic stents, 95% relief, and a relief which is very high even on a 3-year follow-up. This is not our slide. It is borrowed when Professor Costamania came to us. 3 pancreatic stents, 1 biliary stent in case of CBD and biliary strictures. Well, metal stents can't be far behind. We initially had straight, simple covered stents which had a problem of migration. The Koreans invented a bumpy stent, which when placed, the bumps, you know, take up to the contour of the pancreatic duct, but we still are not sure of the long-term efficiency. And there is always a issue that their inner flange, however soft you make it, can hit upon the undamaged duct and produce a de novo stricture. So this is again, the jury is out here. And what do the guidelines say? This is the latest guidelines. Only ISG has given guidelines. They say that ideally a single stent should be tried for a year before you call it refractory. And I have not mentioned in this, metal stents are only to be used if it is in the setting of a trial. Don't use it in a routine patient. So the advice for all of you practitioners is, who are starting their career, single or multiple plastic stents, full stop. What about CBD strictures? You get them in as high as 50%, but many are asymptomatic. And the crucial thing is, they respond very poorly to plastic stent, especially if there is a pancreatic head calcification. It is the single most important factor in a poor response. Again, a meta-analysis, varying results in single and multiple stents from 10 to 90%. You can see the results. We did a study. Here we are putting multiple pancreatic stents. See the second arrow. Oh, it's gone back. The second arrow is in the dilated PD. It's just showing chronic pancreatitis with multiple stents in the CBD. 2014, we had a multi-center study. We contributed out of the 180 patients, 77 of pancreatitis from our center. 1 year dwelling time, migration 20%, good success rate. This is the study from the same one. And then there was a review same time which showed a fully covered metal stent showing a response close to 80% compared to less than 40% for plastic stenting. Sandeep did a same study, a long-term follow-up, 5 years, good response in 60, and there are two factors where it doesn't work. One is the length of the stricture, where it is 2.3 plus or minus a little, or the severity of pancreatitis. Severe pancreatitis, long CVD stricture, poor response. Let us move on to calculi. This is what we get in our country. I'm not talking about alcohol. Large calculi in the head and body, calculi in the head, body and tail. Young adults, dense, mostly non-alcoholic. What do we do? Small calculi. I'm not playing any videos because I'm sure this platform will not support videos. Standard ERCP, remove it. Large calculi, we have got three things and we'll talk about them one by one. This is a video we are not showing, but on the right, I just wanted to throw, sometimes if you are lucky, a large impacted calculi 6 centimeters long, we are able to remove endoscopically also, but this is a rarity, an exception. Why don't we use a Domia basket? For two reasons. Complications are 3 times higher as compared to biliary, and the success rate is terrible, less than 10%. Same with spicoscopy. It is now accepted. You know, it's a challenging procedure. You need special training, special equipment, and there is a greater incidence of complications. What the guideline says, only if a good ESWL has failed, then under expert guidance, you must try spicoscope, pancreatoscope, and lithotripsy. And why does this happen? For two reasons. The PD is tortuous. It's not like the CBD straight where you can pass in a scope. The scope, mostly the fibers break. Second, the diameter is not big. You need a fairly good, 10 French is the size of the spicoscope. You need a large diameter and sometimes it's not there. So again, coming back to the guidelines, I think without fail, they say that if the calculi are large, you must subject them to ESWL. And how do you make a ESWL successful? Choose the right patient. And so this was a question. Do we need to do anything if pain is not there? The answer is no. Ideal indication, large calculi, head and proximal body where pain is present. Don't do it in a patient with a mass with multiple calculi, multiple strictures, pregnancy, and of course, if you have cholangitis due to CBD, first correct it before you send it to ESWL. So coming to our 3 index cases, the first one is ideal, head and second one, yes, if you are good at ESWL, head and proximal body. The third one is extensive, send it to your surgical colleagues. Some photos pre and post showing a lovely clearance and stenting. In a divisum, very large calculi, totally cleared, and we have pushed the stent. We, of course, I told you, we are fortunate to have a lot of data, and over time we have presented it in various series. It started 10 years back with 1,000 cases, and the last one is exactly last year, 10 years later, more than 5. We now have 7,000 cases with some very good results. Clearance, short-term pain relief. And we compared it with our, those time the highest in the world. This was the chart. And you see response is seen in 48 to 85%. We were somewhere in the 80s. Now, this is a disease of the young, especially in our country. So there's no point in getting a relief for 2 years or 3 years. We had a follow-up of up to 8 years and found that 60% of the patients, this follow-up is now 14 years, and we are on the way to publishing that also. 14 years follow-up, 60% relief, surgery has been avoided. So there is a definite role if you select the patients properly in long-term and short-term relief with ESWL. You measure success in the term of quality, pain relief. Again, Shiva, we used VAS score. We use it for analgesic use and number of hospitalizations. Leaks are extravasations of the PD. They can occur not only in chronic pancreatitis, in traumatic areas where there's no pancreatitis, or in acute pancreatitis. It can lead to any of this, ascites, effusion, or a fistula. This is a classical leak, chronic pancreatitis in the mid-body and going into the left pleura. If you are able to bridge the leak, disconnected duct is something which I'm not talking today because that's a topic in itself. You get a 90% resolution. Even if you can't bridge, just place it proximal and you'll get a 50% resolution. And just make a transpapillary cut, you can get a relief in a decent number. One of our registrars, who's now a consultant, did this study. We presented it a decade ago. You see the last figure. If you do it early, the cost in rupees was 90,000 if you did it early, and if you kept it long and treated with taps, antibiotics, the cost went up to 3 lakhs. So if you feel is a good candidate, do it early. And these are from the same study. Leaks in the mid-body, covered. Leaks in the mid-body, stented across, good relief. Finally, very briefly, because I am not an endosono man, but I'd like to tell the newcomers, especially that this is the new modality now established, diagnostic for early chronic pancreatitis. It is the best method to establish. Whereas for therapeutic, pseudocyst drainage is ideally done using an endosono. I have not done an ERCP guided drainage for the last 6 years. Because we have got an excellent team who's doing endosono, because you can tackle the advantages are away from the wall, you can identify the vessels, you can go into the dependent area, and you can also see the response to your drainage. So endosono has become the standard modality of draining fluid collections and wounds. There's no video, so there's no point in playing this. We will move ahead. Sometimes for technical reasons, it is between 5 to 10%. You're just not able, either there is a narrowing of the duodenum or you're not able to access the PD. In expert hands, EUS can be used to enter the PD, and antigrade, you can pass a wire or a stent. This needs expert hands, and the success in different studies varies from 75 to 90%. I told you celiac block for all those patients who have no response. Either you have cleared the ducts or they are small duct and all you have tried. You can either, your radiology colleague can do it, or an endosono guided it can be done. Response, however, is not very encouraging. We did a study and found a 60% response only. But there are studies to show that it is superior to fluoroscopy as EUS guided. You can have, again, there's a debate, ganglion or the nerve. That I think we'll leave it for another day. The final few slides, surgery. 2 decades ago, surgery was the only treatment for chronic pancreatitis. It still is for many cases. And you have these papers which strongly indicated that surgery is better than endoscopic management. Cahen study and 4 others were there, but there is a limitation. There were only 39 patients. Selection bias was there. So we will again not go into the debate. What we have to decide is not whether to do surgery or endotherapy, but which is a good patient for surgery and which is a good patient for endotherapy. That is it. They are not competitive, they are complementary strategies. And it is the clinician who judges who goes where. And my next slide will tell you how we summarize. Since, of course, I am a gastroenterologist and an endotherapy, I will definitely highlight the benefits of endotherapy. You see the last line. In properly selected cases, endotherapy is offered as the first line of treatment for CP. High success rate, low morbidity, you can repeat the procedures, and even if you fail, you don't hinder a subsequent surgery. And this just about summarizes it. Non-dilated ducts, medical treatment, you can do a sphincterotomy, medical includes everything. A ganglion block. Pancreatitis is very extreme and very few people adapt to it. Non-dilated, pain dominant. Dilated duct, if you have ESWL indication or a stricture in the head, ideally do an endotherapy. Failure, or if there is a chain of lake, multiple calculi, or a mass where you're not sure whether it's malignant or inflammatory, call your surgical colleagues. So again, the emphasis is on deciding on each individual basis which goes where, medical, endo, or surgery. Thank you for listening. And should I take up some questions, SP, or do you want me to wait for their questions?
Manu, I think, Manu, if you could stop sharing your PPT, if this is your last slide.
Yeah, I have a few questions to ask. As should I put it first, or should I leave it for the end?
First, you start with a question. While the question is being answered by the audience, we can take up a few questions which I'll put to you.
Okay.
Answers. Let's have
your first question. Govind, Yogita, this is my first question for people who have heard this. You will have to give a feedback, and Yogita will tell us which is not an indication for biliary sphincterotomy. Mostly the webinars are boring, so many people tend to log on and go to sleep. So let's see. SP is laughing because he and I sleep in most of them, no? So I want the answer to this. Yogita, if you get an answer, tell me. Otherwise I'll give the answer. Majority where?
No. Answers to come on the poll.
Next question. I'll do the next question and then you will take up.
No, Manu. Let's wait for the answers,
okay.
No? Okay. So maybe we can take up a few questions from the chat box while we wait and Yogita and we tells us the answers.
Okay, Manu bhai, there's a question of what is the rationale of putting in a stent when the PD is dilated and the patient is having pain?
I'll tell you, there are two patient dilated without anything, without a stricture or stone. That's what I assume.
The question is from Dr. Chandrakant from your institute.
Yeah, I agree, but Chandrakant is a tough fellow to answer. If there is a stricture or a stone, it is obvious. If there is no stricture or stone and pain is dominant and still not responding, I showed you in a slide, 65% of patients will respond to sphincterotomy plus minus drainage.
That's right. I think then the inference is that the level of obstruction is at the sphincter. The sphincter is the site of obstruction and is causing the pain. And so if that system is dilated and there is pain,
the pressure will go off.
In doing a sphincterotomy and
plus minus stent.
Adequate sphincterotomy or stenting.
Right. There's a question from Dr. Rajendra Patel from Mangalore. Pancreatic duct involvement in the tail and patient cannot be undertaken for surgery. What do you do?
The two things happen there, Dr. Patel. One, generally the tail symptoms are minor because the distal obstruction, there is very little duct which can cause ductal hypertension. The two riders I'm adding, this is only new, it was not when we published. We have a new machine now which we can focus very well on the tail without damaging the spleen. The biggest danger in ESWL was in the tail was if you hammered, you will produce a splenic infarct or a hematoma. Now, what we did was with this new machine, isolated cases where pain is still dominant and we feel nothing will work, we have done it. But please don't try it unless you have a real high-end machine.
But Manu, how commonly do you find there is significant bothersome pain in a person?
Very
with
less, very less, very less.
So it is really seldom a clinical problem.
Yes, I told you the amount of duct distal is very nominal.
Important.
So Manu, Vivek and Govind, most of the people were awake. They have given
Yes,
the right
they
answer
were.
GPT more than 2 times. Elevated is not an indication for biliary syndrome.
Correct.
So maybe we can have your second question, Manu.
Second question.
Okay, Yogita, I'll go to the second question. Oh, I'll have to share my slide again. Dhruv, 1 minute, give me a minute, I'll come back to the...
Doesn't matter, so we can go to the, more discussion.
No,
Right. So
Yeah.
I think Manu, one of the, while we get that slide, yeah, okay.
Yeah, I have come now. The second question is, it's not...
This was already done.
yeah, it's not
Next one.
moving.
Next slide.
Now, we had this study where we put CSEMs for long time. What are the indicators? These are multiple answers. You have to tell where you get a poor response for biliary stricture in CP. This was a study of 5 years follow-up.
And it is for covered SEMS.
Covered SEMS, CSEMs.
Okay.
Now we can go to the questions, Vivek.
No, but it has to remain on the...
Yeah. Let this be on while people answer.
Yes.
And so, Manu, I think the classification of pain has been a concern. People, apart from the early Aman et al., they talked about type A, type B pain.
Yeah.
Has there been any further improvements in, this is a question from Dr. Aniket in Delhi. Has there been any improvement in the pain classification? And can you tailor your management to the pain pattern? What are your thoughts?
Even Roop has published a paper where he has said ABCD type of pain, but Vivek, the truth is there's really nothing which is validated. ISB was specific for pancreas. It is too complicated to apply. We don't use it. I cannot give you the details because that's a study in progress, but we had that preview meeting I told you with the Scandinavian group, that pain pressure, there is an objective measurement. They have done a measure. There is a device they have devised. Now that I cannot tell, but probably in a year we will have an objective measure, not a subjective measure.
Can we have shorter answers because...
Yeah, subjective. So the answer is no. No standard therapy. No standard marker.
So,
So one question is there...
Manu Joshi from Haldwani wants to know, when will you use coated and when will you use uncoated enzyme preparations for various indications?
We have no uncoated enzyme preparations of late available. If something is there, I really don't know.
Okay.
We only have coated, so there's no option.
Right. So can we go through the answers? Manu, are you seeing the answers on your screen?
Yeah, I think they have followed. SP, I and you are the only exceptions who don't listen. Everyone else is listening.
Yeah. So you agree with this?
Yes, I think they've done a good job.
Yeah, two things are there. Bad response will be there if there's a long, bile duct is dilated. And secondly, if you have bad chronic pancreatitis. So there are two factors.
Right. Okay. So I think an important question has come from Professor Thayumanavan in Chennai. He wants to know what are the criteria that you will use to diagnose minimal chronic disease in the pancreas or small duct chronic pancreatitis. Are there any objective criteria or it is only the absence of dilatation and presence of pain, so it must be small ducts?
We use that only for practical purposes, but Tayu, there are two classifications, the Cambridge classification and the Kramer classification. Basically, they are main duct. 432 is our normal diameter, 432. They do the primary branches and the secondary branches. Depending on that, Kramer puts it in 1, 2, 3. We followed Kramer, I told you, because Kramer But for us, the practical thing is do a good MRCP, or if you're doing an ERCP,
Right.
see the ductal diameter 432 and then go ahead.
So, again, the criteria is what? Pain is present. There is no other disease suggestive of chronic pancreatitis, and the ducts are normal caliber. Then you will call
No,
it.
there is evidence of chronic pancreatitis. Pain could be anything else also.
Yes.
Evidence of CP without the duct being more than 432.
This is endosono evidence.
Endosono evidence of salt pepper appearance.
Endosono, you should tell Roseman criteria. Some follow it, some don't follow it. MRCP is 432.
Yeah, that is normal ducts. So that is says that the ducts
anything
are normal.
more than that will be abnormal.
No, Manu bhai, how do you diagnose minimal pancreatitis one and except for
many 5 and 4 criteria? A person in the audience who does ultrasound will know better. Fibrosis, those specks come. Stones, of course, they are definitive and probable criteria.
Your colleague from Hyderabad, Ajit Kumar, asks, is there a role of medium chain triglycerides in treating steatorrhea?
MCT. Yes, in dietary management, definitely people suggest, because it goes directly in there in the portal system.
Coordination.
Dietary management.
Then there's a question from Mumbai. Dr. Kole is asking, in cirrhosis in chronic pancreatitis, if we are not able to get to the site of the leak after cystogastrostomy, is there a role of PD stenting?
I didn't follow that actually.
So there's a pseudocyst.
And there is a leak.
There's a leak too.
If you can't go to it, put it proximal to the leak. Yes. You still will get a response in more than 50 to 60%.
Even a sphincterotomy may help.
Yes, the pressure immediately drops and the drainage comes into the duodenum.
Right. I think regarding screening of chronic pancreatitis for cancer, there are a couple of interesting questions. Dr. Alwyn from Madurai wants to know what should be the protocol. Are all chronic pancreatitis patients candidates for surveillance for carcinoma pancreas? And if so, what strategy ought to be followed?
Okay. There are two things. I don't know if he has heard Dr. Suresh Chari or read his paper. Ramesh, Ramesh, of course, from Cochin gave an incidence which was very high, 10 to 15% after 10 years or so. We feel the incidence is lesser, but anyone with long standing and weight loss will need a screening for, not due to diabetes, will need screening. Chari had a very nice algorithm. De novo diabetes in long standing CP or a sudden worsening of diabetes in a long standing CP is a marker where you need to intensify your search for malignancy.
I think the question was also about what strategy will you follow to screen CP? Not which patient, that is one part of it, but what will you do based on imaging, some serologic markers?
Imaging. First, tumor markers and imaging.
But this is a very difficult topic.
Imaging may also include PET.
That's what they're asking.
That you're too tough is a tumor markers, imaging, including PET if you are having a high doubt.
Manu bhai, there's a question from Dr. Rajiv from Delhi. Dilated pancreatic duct differentiating main duct IPMN from chronic pancreatitis.
A good EUS man will do it and aspirate it and show us this thing.
And if you can see the jelly-like material coming from the papilla,
mucin, if you can see fish mouth appearance, well and good.
So Dr. Divakar Reddy from Chandigarh, can we supplement all fat-soluble vitamins in chronic pancreatitis? Do you supplement fat-soluble vitamins?
Yes, you should. If there is malnutrition, definitely ADEK. If there is malnutrition, yes.
Seeing the questions on Facebook?
So all the questions are posted out here, sir, in the chat box. So do we have some more basic question to ask? Or
I think nothing, but I think probably is worth reiterating because many people have asked these questions. I mean, you have repeatedly said that only treatment is required if there is pain. So if there are multiple calculi and no pain, no treatment is required. Similarly, if there is no pain, then pancreatic enzyme and antioxidant therapy need not be started.
Yes.
And again, like Dr. Rajiv from Delhi wants to know if there are dilated ducts and the gland is atrophic, but there is no stone or stricture. Does it need management?
No, pain. If pain is there, yes.
No, no, but even if there's a atrophic duct, you have steatorrhea, then you treat that.
You
Yeah.
can make a cut because the juice flow will be higher.
Okay. I think Dr. Govind, we have covered most of the important questions. I think Professor P.K. Reddy from Chennai has a comment for you, Manu, that lateral LPJ will clear all stones easily and in one setting. So
Yes.
we need to keep that in mind, that while endotherapy is advancing, surgical techniques, approach,
Yes,
and
yes.
expertise
I
is
told you
also
that's a
advancing.
debate which will not end, and there is a definite indication there and a definite indication here.
Right.
So with this, I think we come to uh, end of this very important topic on management of chronic pancreatitis. And Dr. Manu, this has been a wonderful talk, giving all the practical tips. How do you treat pain? How do you treat malabsorption? How do you treat if there are any obstructing stones and stricture? And how do you manage bile ducts in chronic pancreatitis? This has been a treat to listen to you, and your huge amount of experience in chronic pancreatitis. I think all of us got benefit out of your very crisp and clear talk on the practical aspect of treating chronic pancreatitis. Thank you, Dr. Mishra, for again coming back to moderate this session. And again, so good to see you always. Thank you, Dr. Saraswat, for moderating this session. And so we have a couple of announcements before we log off. The first one that we have been saying that this year our annual conference will be held on December 19 and 20. That's a Saturday and Sunday. And this will be a virtual format. We will have abstracts and all the awards and all the award sessions on paper presentations. May we request all of you to please submit your abstract. The last date of abstract submission is 30th of this August, this end of this month. And please do submit your papers for young investigator and plenary session. Second point we want to highlight, want to bring to your notice is that we are changing now the format of the masterclass. And after discussing, we realized that we should focus some of these sessions on management of GI cancer. As we know, most GI cancer are not treated by one person. Is always a multidisciplinary, multidisciplinary approach, which includes gastroenterologist, radiation oncologist, medical oncologist, surgeons, and team from pain management. And the team is essential for effectively treating these kind of gastrointestinal cancers. And GI cancers, we believe, is a kind of no man's land, because we do part of it, we do diagnosis and palliate as a gastroenterologist, and then we refer back to oncologist. Again, to which oncologist? To radiation, to medical oncologists, to surgeons. And again, there's a not good coordination in many of the institutions. Some of the institutions do have tumor board that all of them sit together and take a combined comprehensive treatment strategy. But that's not available all over the country. Therefore, we thought we focus on these aspects, some of the important aspects on how best to treat GI cancers. And for that, we will have a panel discussion. And if I can share what the plan for this would be, that we will have a series of 7 lectures, and we're starting from next week itself. We will have a talk on gastrointestinal lymphoma. Will be on August 30th, and this will be moderated by Dr. K. Mohan Das from TMC Kolkata, and we will have the moderators. We will have a panelist including Prachi Patel from Tata Memorial, Naveen Khatri from Tata Memorial, and Rimpa Basu from Tata Memorial. So we'll have panel discussion on GI cancers, and we already have a defined points. We are not going to discuss the whole topic, but we are going to discuss only the most important point which we need to know. Like when patient comes with particular cancer, what do you do? When do you refer to whom? And what is done there? So it will be a complete algorithm or simplified algorithm for GI cancer. And starting from next week, we'll do that. And then we talk about carcinoma gallbladder, cholangiocarcinoma, carcinoma pancreas, carcinoma esophageal carcinoma, colorectal carcinoma, and carcinoma of the stomach. So probably by end of the mid of the October, we'll finish this series. And with this, thank you very much, everyone, for joining on a masterclass web stream and also at the and the Facebook. So we need to close this point of time, and we look forward to see you on August 30th. Anybody had any? Okay, we'll log off, and thank you very much. This last 4 sessions were supported by Torrent Pharma. We thank you, Torrent Pharma, for supporting these master classes. Now
Okay,
we can log off, and we see you next week on August 30th. Okay, bye-bye.
Okay, Manu, SP, thank you very much. See you. Bye-bye. ये कौन है? मनीषा के बैठ गई.